So my topic today is the Therapeutic Alliance, the what, why, and how. And just a quick introduction on myself. That's a picture of me there with my 3 children and my wife. That was 5 years ago, so everybody's quite a bit taller now. They've moved on to university and things like that. That's probably the last time we were able to get all 5 of us all together at once and actually get a good picture taken. I practice out at Tall Tree Integrated Health in Victoria. And I won't read all of my bio, but probably the biggest thing I would say is that my interest in manual therapy, persistent pain, and evidence-based practice really led me to Therapeutic Alliance because while I was practicing, what I tended to find was that when I looked at the research around manual therapy and other physical therapy interventions, is that outcomes were kind of equivocal irrespective of what technique you used. So, what we were doing to patients didn't seem to matter nearly as much as how we did it and how we communicated with patients and how we got them on board with treatment. And as you'll see as I go through this presentation, there's lots and lots of evidence to substantiate this. And we saw this all the time in clinical practice as well. Just a couple of my biases before we start. Obviously, this is a pain sciences group, and this is a key component of my clinical practice. But I am going to argue that Therapeutic Alliance isn't just for the pain science patient. The patient with persistent pain definitely needs more of this. They need to be in alignment with you and work together with you. But every one of our patients should expect that we're trying to develop a trusting relationship with them. And for some reason, every picture of a physiotherapist on the internet is them stretching out a hamstring. I can tell you that I very rarely do this in clinical practice. And I will say that my bias for this presentation is that I mostly use the physical therapy research. And I really want to acknowledge there may be some counselors, psychologists, or social workers and other types of those professions. And they've done far more research in this area. I haven't included that as much just because that isn't what I've done, but I still hope that some of the things that I get to, you'll find beneficial. There's 3 components to the talk today. The outline for it is I'm basically going through the what, why, and how. I'm going to try and define Therapeutic Alliance for you. There's a number of different definitions. I'll try and give you the one that they've used in the physical therapy research. I'm going to then go through some of the research on why it's important. And it's actually important for a whole bunch of reasons. That bond with a person with persistent pain or any person who comes through our door is important for a whole host of reasons, all the way from making them more adherent to their treatment, to making them more satisfied with treatment, to not being sued as often. And we'll go through a little bit of that along the way. And I also want to identify some of those key ways that we can do simple things when we're assessing and working with people with persistent pain that helps to improve that Therapeutic Alliance. It doesn't take too much of our day, and getting people to understand that this is a skill that we can work on and we should be frequently reflecting upon this and how we're performing in clinic. And I always say that if I attend a weekend course, or if I go to an evening lecture, if over the course of an hour, I can give you guys one piece of information that changes your clinical practice and you incorporate into your clinical practice, that would make me really thrilled. And I feel like that's a worthwhile endeavor. So I'm really hoping you guys will get at least one thing from me today. So I'm also going to do some storytelling, and might get a little emotional as I do this because this is my 19-year-old daughter. And she has a really good story of her encounters with 5 different practitioners and how important Therapeutic Alliance was to finally getting her better and on the road to recovery. And I'm going to kind of touch back on this as we go through the story. Marissa's on her 2nd year at Western University, and she's living on her own out there. She looks really, really young. She looks like she's 16 or 17. And she called us when she moved out to Ontario, and she said that she was feeling generally unwell, that she kind of felt achy and sick for a few weeks. And she said that she was being easily agitated. And for Marissa, she is a social butterfly, the life of the party, knows everybody, hi, hello, and she really didn't want to be around people that much. And she also complained that she was just generally fatigued and her legs were sore. And the first practitioner that she met, she said she spent an entirety of 2.5 minutes with that practitioner. She was interrupted by 30 seconds into the conversation, told that she had depression, and given a prescription for Wellbutrin and no plan for follow-up. And so that's her first encounter with the medical profession. And I'm going to come back to this story a few times along the way and her different encounters and how they influenced her outcome along the way, because her story gets progressively more and more complex. And she still doesn't get the attention that she probably needed to going along. So what is Therapeutic Alliance? This is from a research study done by a physical therapist. I'm going to probably mispronounce their name, Babatund. But it's essentially that working relationship or positive social connection between the therapist and their client. And I always equate with this with the great family vacation. That is, we know where we're going, we know how we're going to get there, and we're having a great time along the way. And what I think what we're really talking about with patient/clinician is that they were agreeing on goals and how we intervene in treatment. But we also have a bond where we trust each other and that we're working together and that we're connected. And I think that this is one of those things that's very easy to see. And often we talk about healthcare. We really think about the interventional aspect of it, but we don't think about the connection. I think a lot of us go into this, into healthcare as a way to help people, but sometimes that gets lost in the fray of the science. And I think when we have Therapeutic Alliance, both patients and the clinicians can identify that quite readily. You can even see in this picture that warmth between two people. I'm going to say we often refer to these as the soft skills. Soft skills are in no way easy. They're really hard work. And it's hard work to establish that relationship with a patient. And it's very easy to lose that trust if we misspeak or don't give those patients our presence and time. And there's 4 components of Therapeutic Alliance. Collaboration, communication, empathy, and mutual respect. I'm going to really focus on the communication and empathy as we go through here. Mutual respect is quite self-explanatory, and we'll do just a little bit in collaboration. But I love this quote: wherever the art of medicine is loved, there's also a love of humanity. And so often as I was being trained as a clinician, I kept on hearing about the art of what we do as physiotherapists, and that art usually referred to some type of manual therapy technique and the way we applied it. But I really think the art of what we do is that interpersonal communication, that connection with patients. And that's really the center of where healing comes from. So as far as the collaboration goes, we really want to move away from this paternalistic model, this model where we're the expert and we're doing this one-way transmission of information. And I think this is kind of an old school approach, and moving more towards where we're empowering our clients, giving them information so that they can help make decisions. And I think this is particularly important for the person living with persistent pain, because quite often their locus of control is low. They haven't been empowered. They're often feeling frustrated, and giving them the opportunity to participate in decision-making gives them some of that empowerment and makes them feel like they're in control of their disease process. Because really what we're trying to do with a lot of these clients is not to fix them, but to empower them so that they understand their condition and know how to take care of themselves first and foremost. And I love the quote at the bottom: recognize your patient's expertise in themselves. They understand themselves best, and it's important that we understand the viewpoint with which they're coming. And that's a really significant thing that we should always be thinking about with our clients. So empathy is the second part of Therapeutic Alliance, and there's a number of descriptions of empathy and definitions, and I like this one that I've included here, simply based on the fact it's from a medical perspective, and it's this ability to understand the patient's situation, perspective, and feelings, to almost stand in their shoes and see where they're coming from. But it's not enough for us to just have that feeling. It's really important that we communicate with that, with the client, because it's important that their story has been heard. And so often we see that clients come to us and nobody's really taken the time to fully understand and hear their story, because that story is full of useful information. And this is particularly important with the person living with persistent pain, because often it's not just a biological issue, but there's psychosocial components to it that we need to understand in order to help them move forward and act in a therapeutic way. So often the idea of sympathy and empathy come up and how they're different. And I'm not discounting sympathy as being a horrible thing, but sometimes it can come across as being pity. And I really like the second caption where we look at empathy. And this is really what we're trying to work towards with any of our clients, is this collaborative team-based approach where we're both sharing and understanding their perspective, but also working as a team together and empowering them as people to be able to work forward from their problem, and so that they're part of the solution as well, and it's not just us giving them the solutions. Now, empathy is a really, really interesting thing, and when I first read this study, this was one of the first things that keyed me off that, I recognized that empathy was important with each of my clients and connecting with them, but that its effects might be far more powerful than just making a connection that may actually be part of the healing process. So this study was published back in 2009, and essentially half the patients participating in the study got a cold consultation from a physician. So the physician was clinical, didn't ask much about their life, but was matter of fact about everything. But in the enhanced group, those patients received care where the clinician listened, asked probing questions about how they were being affected in their life, and just took a little bit more time. I think it was only about 3 or 4 minutes in the actual study. And they used the care outcome measure as a way to see if they'd achieved therapeutic alliance. And the care outcome measure is the consultation and relational empathy score. And it's 10 questions on a 5-point scale. And I've included the scale at the end of the presentation. It's a really nice checklist just to identify that you're doing a good job of connecting with your patients. And I'll use it to reflect on how I've done with the patient. And it's also not a bad idea to leave at your front desk, for your front desk to give out to clients to see if they're connecting with you and see how you're doing and getting some feedback from your clients. For outcome measures, they looked at the duration and severity of the cold and the client's satisfaction with the care that they got. They also took a nasal swab and looked at the immune system response a couple days later after they'd had their consultation with the physician. And of course, those with perfect care scores were obviously more happy with their consultation, and they actually identified that mutual connectedness, as did the physicians. They were quite adept at figuring out who they'd had a good connection with. And as I would expect, there was decreased cold severity and duration. But what was really interesting was those people who got empathetic care actually had improved immune response. So that connection goes beyond just a transfer of knowledge, but it may be an intimate part of people recovery and healing. And I think if it's that important with the common cold, I wonder how much it contributes to people with persistent pain. And you'll see some research along the way to identify that those patients who have good alliance with their clinicians have better outcomes, and it's a strong treatment effect. And we often think of empathy as being something that somebody is just born with and their ability to be empathetic, and that good bedside manner is just an inherent skill. But in actual fact, it can be taught, improved upon, and it doesn't take a ton of training in order to improve those skills. And in this study, they took 100 physicians and half of them just got standardized education over 3 lunch hours, whereas the other half of the clinicians had 3 one-hour sessions looking to train empathy for their patients. And what they used as an outcome measure was that same care outcome measure. And they did this before they took the course and then 2 months later to see if it had a lasting effect. And these training sessions consisted of being aware of how patients and clinicians communicate, how you can provide an empathetic response, having some emotional self-awareness for the clinician as well, and then also using these skills in challenging situations. And I think we all experience challenging situations when we go to work with clients. And we can all think of those episodes where we might get a little flustered inside, and just learning how to self-regulate seemed to be a beneficial thing. And of course, those clinicians who learned empathetic skills had significantly better care outcome measures 2 months later. And here's some of the things they taught them. The first was to decode emotional cues on people's face and what they were expressing through emotion. They also gave them quick mindful tips, and there's some really nice research on mindfulness suggesting that it helps decrease clinician burnout, but also can help us just self-regulate while we're having those difficult encounters. And they also use some biofeedback for clinicians just to help them down-regulate and learn their physiological response when they're having difficulty with clients. So we're going to get back to Marissa's story. She continues to feel unwell and she starts to develop progressive headaches. She has general body pain and she starts to tell me that she's having difficulties with memory. And I have to say, as her father, I'm doing this over the phone, but this is the information that she conveyed to her physician. She said that I can't remember what happened to me last week. And she went to see the hospital at the University of Western Ontario. She said this next physician stood just by the curtain, ready to leave, walked in, and the first words out of his mouth were, "What dates do you want your note for?" And of course, that kind of communication strategy and prejudging a client before we've even spoken to them, just from a few notes, can only lead to that client feeling they're being dismissed and prejudged. And so, of course, Marissa didn't divulge much information to this fella. And when he said that, she said, "I'm here because I'm sick and I need help." Unfortunately, she only got to give out that much more information before he told her that she had the flu, and there was nothing else to be done for her at the time. So we'll come back to Marissa's story, but this is going to segue into our next component, which is communication. And this is based on a study done by an Australian physiotherapist called Communication That Values Patient Autonomy is Associated with Satisfaction of Care, Systematic Review. So they looked at a number of studies about what type of factors correlated with clients being having high therapeutic alliance and being satisfied with care. There's 12 papers they looked at, and there was 3 components they looked at: and the interaction style, or how they approached the client, what kind of things they said from a verbal perspective, and what they used from nonverbal factors. What kind of body language was there? And I think what we see with verbal and nonverbal is that we get into the biggest trouble when our verbal and nonverbal communication don't match. But the interesting thing, and we're going to keep coming back to this, is that patient-centered care was really one of those things that always kind of panned out to be associated with therapeutic alliance, just like that collaboration that we talked about earlier, working with somebody as opposed to just speaking to them. So what are some of the specifics here? Well, again, facilitating involvement of the patient and supporting the patient, acting like a cheerleader for that patient, reinforcing for all the things that they've done well. From a verbal perspective, getting them involved in the conversation, giving them information, and getting to discuss options and encouraging them to have a clear comprehension of what's going on. And geez, if there's any group that needs this, those people living with persistent pain so often are a little bit more complex, need a little bit more time, and don't have a full understanding. Often they've had multiple interventions and multiple things told to them, and they don't really understand what's important at the time. And just giving them some clear and concise information so they fully understand is really, really important. And interestingly, from a nonverbal perspective, they found that eye contact that was non-dominant was associated with improved therapeutic alliance and improved satisfaction. But what they really found was that those body languages that were closed off led to dissatisfaction. So it wasn't so much that body language helped improve satisfaction, but poor body language really increased dissatisfaction, closing the body off, turning away from the patient, and being unequal. So one person standing, the client sitting, can also lead to that power differential. So all these things we should be considering when we're talking and communicating with our clients. So we get to the next point, which is, why is therapeutic alliance important? And I think I'm going to start with this, particularly for the persistent pain patient, is that for so long in healthcare, we've really looked at, what's the specific biological process that's going on? And we've forgotten, or at least dismissed, a lot of the psychosocial components. But we now know that each one of our clients who comes in, irrespective of what they come in for, is attached and is a bigger picture of biopsychosocial issues. And we really want to understand the totality of that client. And we can't do that just by being cold and impersonal. And in fact, Anderman published this in 2016 in the Canadian Medical Association Journal. And that is that compassion and empathy really lets us understand that whole person. And I love this graph here, where we're really only seeing a small part of the picture if we're really sticking with the typical healthcare component of it. Lots of our health behaviors and socioeconomic issues and physical components all contribute to our experiences in health. And with the persistent pain client, we know that many of these people end up living with anxiety, depression, have poor previous health histories, may have a history of abuse, and things like that that are really, really significant to their experience of pain. It's important that we can understand. And a lot of people really, as you see there, 40% of people report that their GP just doesn't understand where they're coming from. But that therapeutic alliance allows us to ask those tough questions in a thoughtful and meaningful way. And compassion and empathy is really that thing that makes patients come forth with their information and fully divulge. And I think so often we take for granted that somebody is coming in, a complete stranger, and we're expecting them to divulge things that they won't even tell the closest people in their family. And they're not going to do that with the person who is cold and impersonal. So we really use this as a way to understand that person and their perspective. But it goes further than that. And this may be just for your own ego, but when we look at what people experience as being good care, and Potter did this, a qualitative study where she asked patients in physio clinics what constituted a good experience and what constituted a poor experience. Virtually all the responses related to therapeutic alliance, and clients even use the information that we're talking about here, the words. They said things like, the care and concern of my physiotherapist who showed me empathy was an important way to be recognized as having a good experience. Being treated by somebody who listened, they were caring and sympathetic. So somebody who gave clients time and understanding, that was constituted with being a good experience. And interestingly enough, all those things we talked about for about having good therapeutic alliance and what it consisted of, that we agree on goals, we agree on treatment, and we mutually respect each other along the way. Those things were not met when people had poor experiences. I was unsure of the treatment with insufficient explanation of the treatment. So we don't have an agreed process here. Me and the physiotherapist have conflicting opinions about my problems and treatments. And then finally, I did have a physiotherapist once who thought she knew it all and ignored what I said. We can never discount our clients because they are our biggest source of information. But it goes further than just our clients recognizing that people are empathetic and thoughtful, are good clinicians. Dave Walton's a physiotherapist out in Ontario, and he gave me this slide, so I'd like to acknowledge that. He's asked over 400 physiotherapists, what constitutes a good quote unquote physio? And I think this is probably going to apply to most professions that are listening here, but about 80% of the things were not related to our knowledge or clinical skills. They're related to things like being a good communicator, being empathetic and understanding, getting trust from clients, connecting and caring. So not only do clients recognize this, I think we as clinicians recognize this as well. And I think it's valuable that we start to reflect on this more often and try and develop these skills in the clinic. So back to Marissa's story again. This is her picture in the hospital that she sent me. She'd been throwing up regularly. Her headaches were getting progressively worse. Her body pain, again, was getting progressively worse. And when the physician came, again, stood over top of her, and she did get interrupted again before she could disclose any more symptoms. They cleared her because she had quite a bit of neck pain from meningitis, and told her again that she had the flu, despite the fact that she said she'd been feeling like this for 3 months and she didn't think that she could have the flu for 3 months. So the interesting thing is, what other symptoms did Marissa have and not disclose? And I'm going to get to that down the road because she's got another couple of consultations before she gets to that point. But what she did do is go back to the hospital. I implored her to go back. And I said, don't leave until you have somebody else look at you if you don't feel like somebody's listening. Thankfully, she's very strong-willed, despite being young. And I think she almost bullied them into letting her see a neurologist who fortunately was very caring. And we'll get to that in a moment. So the other thing about the Therapeutic Alliance is that it really helps with our intervention and effectiveness. And again, like I spoke at the beginning, my journey towards this was that a lot of manual therapy techniques, although they seem to have some effectiveness in decreasing pain for my clients, didn't seem to matter which one I used. And so I like this analogy that Therapeutic Alliance makes us pushing that ball that much easier than pushing the block. And we know that the person living with persistent pain has a long, tough road ahead. And we want to make that as easy and beneficial as possible. There's some really interesting research on the effectiveness of decreasing pain that Therapeutic Alliance applies. So Fuentes practices or is a professor over at the University of Alberta, and he did a randomized controlled trial, and I love this study and the way he set it up. Essentially, he took 4 treatment groups, 120 clients with persistent low back pain, and what he did was he applied IFC. For those of you who don't know what it is, it's called interferential current. It runs electricity through the back, which in theory helps decrease pain. And for half the patients, they got real interferential current. The machine got turned on so they could feel a buzz in there. The other half of the clients received sham interferential current. So the clinician went in, but the machine was unplugged and they turned it on and turned up the valve. But within those 2 groups, either half of them got a limited interaction. Essentially, the clinician walked in, turned on the machine, then walked out the door and came back 15 minutes later. For the other group, the clinician sat with the client for 15 minutes and asked them about how their pain had affected their life, and to ask them more information about where they were at with their pain and how their recovery was going. And what they used for an outcome was how much pain was decreased right after the treatment and the client's pain pressure thresholds. And I think the findings are really interesting. So those clients who had the real interferential current and had that enhanced interaction with the client tend to have a much greater decrease in pain. In fact, 3 points, which makes total sense. But the interesting part is that the next greatest decrease in pain was not the people who had the IFC turned on, but the ones who actually had the sham IFC, but had the clinician sit there with them and talk about their pain and more fully understand them. So I think the takeaway message that listening and hearing the person with persistent pain is a valuable treatment within itself and can help decrease a client's pain. And this goes on for another study that was conducted, and this trial was embedded into a randomized control trial where they were trying to look at 182 patients, and they had 3 treatment groups. One group received manual therapy, one group received spinal stabilization exercise, and another group received just a general exercise program. And what they did was that on the second visit, they measured therapeutic alliance that the clients felt that they had with their practitioner. And then they looked at the long-term outcome. I believe it was at 3 months after they had treatment. And outcomes that they used were the patient's pain. The PSFS is the patient-specific functional scale. So things in their life and how they can function. The perceived effectiveness of their treatment, and the Roland Morris's back disability questionnaire. So that treatment effect of having good therapeutic alliance was actually quite powerful. It actually accounted for up to 20% of that improvement. So those people had the lowest therapeutic alliance compared to those that had the highest. Those who had the highest had a 20% greater improvement over those that had the lowest. But the interesting thing that for those persistent pain clients, it didn't seem to matter which intervention they were given. All of them demonstrated improvement, but the therapeutic alliance seemed to nudge them up significantly more. And that was across all the outcome measures. So this was quite a consistent effect. We also know that therapeutic alliance is highly correlated with patient satisfaction. Hush looked at some of the physical therapy research for musculoskeletal care, 15 studies. And the good news for us physios listening out there is that satisfaction is generally pretty high. And I would actually account for some of that is that we actually get to spend some significant quality time with our clients and develop a good therapeutic relationship. And I will acknowledge that the biggest thing that was associated was characteristics of caring, friendliness, and professionalism. But organization and process of care are also important. So it's not as simple as we just need to be nice to our patients, that we also want to focus on the quality of our care. But we should also note that the outcome of treatment interventions was very rarely actually associated with patient satisfaction. So patients were more interested in the care that they were provided than the actual treatment outcome. Now, in no way am I suggesting that we should just focus on satisfaction. We want to have good outcomes. But I think that this therapeutic alliance is a big component of how we get those good outcomes. So if you're not convinced yet, there's a number of other reasons to include therapeutic alliance in your practice. There's a number of studies showing that there's improved patient adherence to treatment and that they tend to follow up more if they have high therapeutic alliance. There was just a study recently published on knee osteoarthritis and hip osteoarthritis that clients were most likely to perform their exercises 2 and 6 months later if they had a good therapeutic alliance with their client. And I think this particularly speaks to the patient living with pain because those people we're really asking a lot of them. It's not an easy fix, and we're really looking, if we're giving good pain sciences education, convincing them to get activated, it's never this nice, straight, progressive, easy way to recover. It's really hard work, and they really need as much help as they can. And so if they have good alliance with their clinician, they're much more likely to be adherent to that as a treatment program. And for those of you who are worried about being sued, it turns out that people are most often sued not because of malpractice, but rather because they weren't heard or listened to, or there was a general dislike of the clinician. There was also this thought at one point that if we gave out too much empathy, and that we were too caring, that we would be burnt out. But there was a nice systematic review showing exactly the opposite. People who demonstrated the most empathy for their clients had the most satisfaction with their job and had the least likelihood of burning out. So it seems like the more we give, the more we get. And I really think that most clinicians find great value when we're able to connect with their clients. And when we feel cold and impersonal, I think that's when we start to feel those burnouts and we're not making those connections with clients. So moving on, how can I improve therapeutic alliance today? So I'm really going to try and give you guys some ideas on what you can incorporate into care. And I'll try and keep these as simple as possible. And I know not all of them, everybody can incorporate into clinical practice. And often time seems to be our biggest limitation. But I'm sure some of this you can take away and use in clinical practice. And I've used a paper from 20 years ago called Getting the Most Out of the Clinical Encounter, the 4 Habits model. And it's basically a way to structure your initial assessment with the client. It was written by Frankel 20 years ago. I go and review this once a year and just kind of contemplate about things I may have missed along the way. And thankfully, about 2 weeks ago, this paper just got published. JAMA did a special edition on communication and presence. It's called Practices to Foster Physician Presence and Connection with Patients in the Clinical Encounter. If I was to read 2 papers on things that I could use to help to incorporate some of these things into clinical practice, these would be the 2 that I would read. I think they're absolutely fantastic and a great way to try and improve those skills. These 4 areas that I've listed on here are part of the 4 habits model. So essentially the first habit is to invest in the beginning, structure the patient visit, make sure that patient feels comfortable with you and that you're acknowledging and giving your presence. The second is to listen to their story and get their perspective on everything. And then looking for empathy and demonstrating empathy and making sure that the patient understands that we understand them. And then finally investing in the end. And that really means creating a treatment plan with the patient so that they're part of the process. So I'm going to go into a little bit more depth on this now. This is from that original study, the Practice to Foster Physician Presence. And I love these cues that they talk about, this preparing with intention. And the first one they suggest is that you look at your client's paperwork before you see them. So often these clients spend 15, 20 minutes filling out paperwork only to have the clinician not look. Tell them, hey, I've looked over your paperwork, but now I'd like to really hear your story from you. They also suggest that before we actually go to see our clients, that we make sure that we're centered and that we make a ritualistic habit of that. And so we've got the washing of the hands, and as a medical professional, we should always be washing our hands in between clients. And we can take that moment while we wash our hands and make sure that we're focused. That might take 3 breaths. It might be practicing just a bit of mindfulness and centering ourselves, because the most important thing at that moment is that client in front of you, not the 7 clients ahead of you in the day or the 7 that you've had previously or that difficult encounter that you just had, and focusing on what you're there for and what you're there for that patient. The other thing that they suggest in the article is to look at the shoes of the client just briefly as you come in, as a reminder that we're there to walk in their shoes and understand their story. We also want to invest in the beginning by our appearance and our administration. We know that clients, when they walk in the door, their first contact typically isn't with us. And the people at the front desk are the face of our business or the face of our healthcare. And if they have a poor experience with them, that can make or break our interaction. I also want to again implore that first impressions are made in seconds, like 5, 6, 7 seconds, and we need to make that time count. So be present for your client, greet them warmly, make them feel at ease, and then plan the visit with them so they feel comfortable in that first visit. And then we also want to agree on what matters most. A great way to do that is say, if there was one thing you were hoping to get from me today, what would that one thing be? And that can really clarify what the goal of that client coming in through that day. I love the Dalai Lama and his comment that when you talk, you're only repeating what you already know, but if you listen, you may learn something new. And we're really there to learn something about our clients. Unfortunately, this doesn't often happen in the medical world. In one study, patients were interrupted after only 18 seconds on average. So they really didn't get to speak their full story. And interestingly enough, I think we sometimes fear that the client will continue to speak and speak and speak, particularly if they're rushed and hurried when they first speak. But in actual fact, they looked at over 60 clients in this study, and none of them spoke for longer than 2.5 minutes. And I think we can all agree that we have 2.5 minutes to give to each and every one of our clients to listen. The interesting thing is that most clients do not sequentially list their concerns. So the thing that's most important is not usually the first thing on their mouth. So it's important that we hear that full story. And if we think about the person with persistent pain, and this person coming in who is vulnerable, who's never met you before, is a stranger, and all of a sudden you want to divulge things that you may feel shameful about or embarrassed, whether it be depression, anxiety, which still carries some stigma for certain people. They won't get divulged if we interrupt them. And the interesting thing is, if patients were interrupted, they often get back to those things that were really important. And many times they were psychosocial in nature. And we know that psychosocial component of the client history is just as important as the physical when we're dealing with a person with persistent pain. And certainly I've put there at the bottom, use verbal and nonverbal cues to convey attention. I'm going to go a little bit further. The idea of having our computer to take medical records is really tough, and it really puts a barrier between us and our clients. I suggest that you put it off to the side, at least when they say their initial words. I know we're all rushed, but nothing turns a client off more than you looking down at your computer, or even worse, I've heard of clinicians turning their back on clients and typing at a desk while their patient talks. I put it off to the side. I ask them to tell me their story, and when they're done, I say, hey, I'd just like to clarify and write a few notes. I'll just let you know what I'm going to put down, and I'll ask them to give me clarification to make sure that I've got their story right. And that conveys that I've been listening. So Marissa's story, she finally gets this consultation with a neurologist, and as a father, being a long ways away, the kindness was really, really important to me. And that really struck me. He did a couple things that were very specific that made her feel comfortable to divulge her symptoms that she hadn't divulged to me. First of all, he didn't stand above her. She was very clear about this. He said he took her to another room, had her sit, sat beside her, and offered her a glass of water. And then he also asked, tell me the whole story, beginning to end. And he'd already told her that I've read your notes, but I really want to hear the whole story. And then he clarified everything at the end with her. And so the additional symptoms that she's had was she was hearing voices, she had paranoid thoughts, and she had totally isolated herself from any of her friends. And she really was confused and didn't really know what's going on. And I want you to know that she has a good ending to this story, actually a really good ending. She had a very rare diagnosis, but it took that care in order for them to get that. So we really want to listen to that patient's perspective. And so often when we're dealing with that client with persistent pain, it's really as much about the biological as the psychosocial and the narrative that they're telling themselves. Because often what we're rewriting is really the narrative, how they're interpreting their symptoms and what they believe is going on. And so often when we start to ask questions like, what do you think caused this? Or what is your biggest concern? I just had a patient a couple months ago who had acute neck pain, had just tweaked their neck. And really at outset, if I hadn't asked some questions, I wouldn't have got this information. I said, what is your biggest concern? And she said to me, you know, my dad got cancer and his first sign was that he had low back pain. I'm wondering if I have cancer. Now that discussion that I have with that client is more, much more difficult and much more explanatory than if I just assumed that this was just a simple tweaking of the neck. And again, getting back to that treatment expectations, what are you hoping to get from me today? And as long as the treatment intervention isn't dangerous, asking what their expectation, what they expect will help them recover, often drives outcomes as well. We know that expectations are strongly linked to outcome. So we would be dismissive, and it would be foolish of us not to figure out what they were hoping to get from us. And then we also want to figure out what the impact on their life is. That'll help us set goals, and also tells that client that we're interested in more just their biology, but that we're also interested in how their functioning from a day to day, and understanding their whole psychosocial components of their pain. And it's not enough for us just to hear a client. We also have to demonstrate empathy. And I think sometimes we're remiss and we fear bringing up emotional things. But we should really look for windows of opportunity. Look for those hints of emotion as we discuss things. And those hints might be a little falter in their speech. I think I did it just a little while ago, if everybody noticed. Or it might be hesitation. And using those as cues to help us explore and things like, hey, I can't help but notice you just hesitated for a minute when you spoke about your mom, or something like that. And often that'll end up telling us a little bit more about that totality of experience for that person living with persistent pain. We also want to demonstrate that empathy. So it's not enough just for us to hear, but convey to that client that we are seeing things from their perspective and walking in their shoes. And it really lets them know that the patient's problem has been heard and their problem understood. And I know this feels like it's going to take up more time, but in actual fact, I think a lot of the time, once people have been heard, it prevents them from going on and almost speaking over and over again the same thing, because the reason people do that is because they feel they haven't been heard and their story hasn't been heard. There's a horrible Twitter video where a nurse did this mock of clients and basically saying that clients were faking things in the ER when she saw them. And there was a hashtag that came out that said, patients are not faking it. And it went viral, and I think 70,000 people responded to it. And when we do get those clients who come in, who their symptoms may be out of proportion with what we would think they would be, I think it's really important that we think and take a moment and understand that these clients are still suffering and that something may be going on, and we don't fully understand their picture. We don't know what happened to them last night. We don't know what happened to them in their childhood, or what else is going on in their life that caused them to behave that way. So that there may be other things that we need to key on, and that we should really be demonstrating empathy for everybody who walks through our door. Carl Rogers has this great quote, and I really think for the person living with persistent pain, they're so often dismissed, not heard, confused, and alienated. And I'm just going to read this to you. And I really believe that hearing and connecting is a powerful, powerful way in which we help clients recover. So when the other person is hurting, confused, troubled, anxious, alienated, and terrified, and this sounds like the persistent pain client when they're really struggling, or when she's doubtful of self-worth, uncertain as to identity, then understanding is called for. The gentle and sensitive companionship of an empathetic stance provides illumination and healing. In such situations, deep understanding is, I believe, the most precious gift one can give to another. And we should be really striving for this on a daily basis. So finally, we want to invest in the end with our clients. When we deliver our information, we want to be very clear about it. And we also want to give them options, so to empower them what they can do about it. Not just what we can do to them, but what they can start to do to take on and really become the drivers in their situation. And this goes towards them helping to make decisions. Ask them what they know about the condition, what have they had before, and what's worked, what hasn't, what's their previous experiences, and what do they think will work in the future. Again, we'll figure out their expectations and making that treatment clearly with the patient. And then finally, once we've given that information, really important to check in, make sure that they understand the information they're given. Do they have any questions? And actually, I really make a point as we go through, on multiple occasions, ask if they have any questions. Does this all make sense? Because people are often hesitant to ask questions, and it's not till the second or third time that you probe and make sure that they really feel that you want to understand them. Another way to do this, if you have time, is to say, hey, when you go home today, what are you going to tell a family member about what we discussed and what's going on? And then finally, check in and make sure that we've met their expectations. Now, if you're doing all these previous steps, often they'll say, no, this is above and beyond what I was expecting. But if we haven't met their expectations, we can clarify and say, hey, let's get to that first thing next time you come in, and we'll make sure that's taken care of as well. And finally, I really want to focus on positivity. We're there. These people are struggling. Often socially, they're having difficulties. Emotionally, they're having difficulties, along with physically. We want to celebrate their successes, pat them on the back, give them a high five, and cheerlead them as much as we can. And when they have a downfall or a flare-up, turn that negative into a positive. And I'll give you my example I use in clinical practice. Low back pain is a recurrent thing, and often clients improve with pain science education, activation, physical therapy, but they'll have flare-ups and then they feel defeated again. And I tell them that let's turn that into a positive. If I can settle that down and get on it, and as a clinician, as a patient, I know what to do, and I calm my symptoms in 2 or 3 days, I got this thing beat. I'm in charge. I don't have to fear the flare-up anymore, because we know fear drives back pain a lot of the time. So really trying to flip the switch that some of those negatives can become positive and help pick them up, dust them off, and get at it again. So this is that consultation and relational empathy checklist. It's 10 items, and I think they relate really well to what we were speaking about. So get the patient feel at ease and get to tell their story and feel heard, right? And that listening aspect of things being really important. Do the clinician demonstrate interest in the whole person, identify and understand the patient's concerns? Were they compassionate and act with positivity? Was there a clear explanation for patients? And in that action plan, was the patient given a chance to take control and become part of the treatment team and really move forward? And again, I can't emphasize how important this is, that we're giving clients back control when they're presenting with persistent pain. And just to finish off, that's a picture of Marissa looking quite a bit healthier. She had a very rare condition called autoimmune encephalitis. For those of you who don't know what it is, it's swelling on the brain that caused by an autoimmune response. Often occurs with young females. The vast majority of the times when it's first caught is when they're completely catatonic or completely psychotic. And it's got a 7% mortality rate. So it was a serious condition. She had 8 weeks of treatment, and the news earlier this week from a spinal tap was that she's in remission. They're going to have to monitor her, but she's resumed studying, and unfortunately from her father's perspective, a whole bunch of partying. But I think her story really speaks to how we can get more information, how important Therapeutic Alliance is. So in summary, Therapeutic Alliance is a critical skill that influences a whole host of things, but in particular, client satisfaction and clinical outcomes. And it's something we shouldn't just take for granted. There's something we can continually improve upon. And there's lots of small things that can be done to improve Therapeutic Alliance. So hopefully, I really hope you guys are interested. For those of you too shy to ask questions, I'm happy to take emails. And I recognize that some of you listening are probably great experts, but let's go with some questions. I think we're right on time here. Jen, do I need to do something here for the stop here?
You don't need to do anything,
okay.
Steve. Yeah, that was great. Really interesting presentation. Thanks for that. So we have one question from Natasha. This is a good question. I'm sure many people are thinking about this. Do you have any tips on how to engage a patient who is unwilling and not involved with their recovery? How can you as a therapist help her help herself? And continuing from that, there are many layers to her trauma, and I'm not sure which way to direct her.
Yeah, it's always hard to speak to an individual case with knowing a whole bunch, but I think as I've practiced for longer and longer, if you have that Therapeutic Alliance and that client feels disengaged, I think asking them why they feel disengaged and even making a comment on it, not in an accusatory manner, but something along the lines like, I can't help but notice that it feels like you're not as engaged in this treatment. Is there something that we need to do to get you on board? Or is there some other way that we need to take this? And just kind of delving in gently into that area. Now, I'm not sure what Natasha's profession is, but if there seems to be a lot of emotional, trauma-based type issues, I certainly would want to get a counselor or psychologist involved in care, and a team-based approach if it's that complex. I hope that answers the question. Natasha, please feel free to do a little follow-up question.
I have a follow-up question. Do you ever use motivational interviewing or any of those sorts of techniques?
Yeah, absolutely. And I will say that motivational interviewing, I understand, is a huge topic. And I've only read about it and not taken a whole bunch of courses on it. I think good clinicians use some of this inherently, but I absolutely think that it's really interesting. As a physio, we were always taught interventions with exercise, manual therapy, things like that. And I'm starting to realize, particularly with clients with persistent pain, what we're really looking towards is changing a narrative and causing behavioral change. And that doesn't occur when we give one-way transmission of information. And as I practice longer and longer, I find myself pausing more, listening more, and questioning more. And I think that's part of that motivational interviewing. And I wish I could say I'm an expert on it. I have great respect for it. I try to incorporate some into clinical practice, but I don't want to portray myself as being an expert in that field. But I'm only wanting to learn more about it.
Well, I'll put a plug in for our Echo,
Yeah.
our Echo for chronic pain. It does have, we did do a session on a very introductory, but there was a little bit of information about motivational interviewing. If anyone listening is interested, you just have the Echo and you sign up for the Echo and you can see the recording. Sort of following on that, Steve, though, just because Natasha's mentioned the trauma piece and how, like, I mean, you're a physiotherapist, right? Like, so how do you kind of manage, like, I imagine you get into some pretty deep emotional stuff with people. How do you just like reconcile the kind of scope of practice that you probably have, right?
Yeah,
And
yeah, absolutely.
when you get into this emotional piece, how do you manage that?
Yeah, so there's a fine line for sure, and absolutely. One of the big questions that I ask virtually anybody coming with persistent pain, and it always has to be done, particularly as a physiotherapist, in a caring and thoughtful manner, is that after I hear the story, and particularly if I'm picking up on some of that emotion, is that I say something along the lines of often people experiencing persistent pain often have feelings of depression or anxiety, and I'm just wondering if any of those things are happening with you, or you feel like you need help in those kind of areas. And to be honest, most often I've never had somebody upset about it, and I've had lots of thank you. Nobody else has asked me, and so I think clients are willing to divulge some of this. Now, certainly, if it's depression, I ask that they consult with their family physician and get back to them. If it's significant depression, absolutely some counseling or significant previous trauma, counseling, psychology, and communicating. And I'm fortunate to live or work in a clinic where I have access to some of those things, and I've always had that kind of access. And it is important to recognize our limits, but that emotional connection and divulging is part of the whole person. And I don't think we can look at people as body parts. We need to look at them as their entirety and recognize those emotions. And that's just about being connected to someone. So I hope that clarifies it. And I hope nobody feels like I'm overstepping my bounds there.
That's a great answer. Thanks. Appreciate that. Okay, Dan has a question. This is a good question too, really thoughtful. Do you ever find that patients feel invalidated or unheard with the cheerleading and focusing on the positive? Do they experience it as maybe a lack of understanding and empathy? You're sort of like persistently cheerful and they're saying, but I'm really hurting here.
Yeah. Well, we definitely need that balance, right? So we can't just cheerlead. If that cheerleading comes from a point of, first of all, recognizing and hearing, and I hear that you're really hurting now, but I know that you can get back on track. And I've seen this kind of presentation before, and it can be really, you're right. If we go straight to the cheerleading, oh, you're fine, you're gonna be okay, that's dismissive. But if we take that moment to listen and to acknowledge and really hear them out, and then get to a point where we can say, hey, but look at some of these other things or where you've come from, but we have to be genuine about that as well. So we definitely want to include positivity, but that doesn't mean that we're discounting that client's experience. So it is a balance, and that's a great question, Dan. And I hope it didn't come across as we're just saying, go, 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 you're the greatest. But we're giving more of a focus. Unfortunately, I see so often that clients living with persistent pain are given so much negative messaging. And so my focus here is to give some of that positive messaging, because a lot of that negative messaging is disabling.
Yeah, that's, thanks for that clarification. I think that's really helpful, Steve. Okay, Dan's got another question. What role do you find manual therapy application plays in creating and supporting a therapeutic alliance? Do you find you find the choice of technique plays a part?
Yeah, so that's a really good question as well. So, I always say when I'm working with a client who's got persistent pain, that education is non-negotiable, and experiential learning, whether that be through exercise or general activity, is non-negotiable. But manual therapy is negotiable. First of all, particularly if we're dealing with a persistent pain client, we in no way want to give this some type of biological label where we're putting something into place or giving some kind of idea of fragility to our clients. What I tell clients, if I'm going to use it, is this is simply to get that system to calm down so that you can get moving. This isn't the main focus of your treatment. And that we really want to find a treatment that improves your mobility and makes you move better. And it's simply for the short term, but long term, we want you to learn how to get yourself moving and take care of this yourself. And so I'm not using it all the time with my persistent pain clients. I probably included it a bit there because that's the evolution of how I got to this point. Hopefully that clarifies it for you, Dan. I think that's a great question. But really staying away from any of that negative language that can be associated with manual therapy, and only using it as one small component of treatment if I choose to use it, whereas understanding the client, education, and activation are the bigger emphasis with that person with persistent pain.
Awesome. I don't think we have any more questions.
Oh, great. I've answered every question through my very thorough presentation.
And we're right on time.
Perfect.
Even better. So Steve, that was a great presentation. We got some comments in the chat just appreciating your approach and just bringing both the evidence and the humanistic qualities to your presentation. Rebecca wanted to let you know about that. So
I think I know who Rebecca is. Yeah.
Appreciate feedback.
Yeah, if anybody has any questions or comments, please feel free to contact me. I don't know if I'm allowed to say this, but I'm happy to share the articles if somebody is interested, although I don't know if that's savvy.
Yeah, well, we'll send out, after this, we'll send out the recording and we will send out the presentation. And yeah, I just appreciate your time today and appreciate the time of everyone on the call. Thanks so much, and hope everyone has a great rest of the day.
Thanks, guys, for listening.
Bye-bye.